and to the GI system and the muscular vasculature as well. So with the dosing, we start at 0.04 units per minute, and this is non-titratable. Although here at this institution, we do have a dose of 0.4 units per minute for a bleeding dose. But with that, we have to be very careful with vasopressin. Because of that coronary vasoconstriction, it can lead to MI. So we have to be very careful with that. This can cause bradyarrhythmias as well. So back over here to our board, it doesn't hit any particular receptor, so I'm just going to put like a little brown box there. Is this going to do anything to our CVP? Absolutely, yes. So we're going to have an increase in our volume, therefore an increase in our preloaded CVP. How about cardiac output and index? Not really. Systemic vascular resistance? Not really either. So it's a great at increasing that preload. Therefore, what type of shock would you expect to use this medication in? Hypovolemic shock, exactly. You would use this in bleeding and hypovolemic shock. Awesome. All right, so dopamine. Dopamine is our wild card, which is why I got a wild card here on the presentation. Dopamine hits all of the receptors, including dopamine receptors, which we're not going to go into, but you can see it there on your pressor speedometer in front of you. So it hits the beta, beta 2, beta 1, and alpha 1 receptors. So back over here to our board, we begin at the beta 2s. It moves forward to the beta 1s and on to alpha 1. Now, if dopamine hits all of these receptors, what's that going to look like hemodynamically? What's it going to do? It's going to not really do a whole lot for our CVP. How about our cardiac output, cardiac index? Yeah? Since it's hitting that beta. How about the systemic vascular resistance? Well, let's go into that and we'll come back. So at very low doses, dopamine can be used to promote cerebral perfusion and renal perfusion because of that beta 2 and the dilation. In moderate doses at 5 to 10 mics per kilogram a minute, dopamine can be used as an inotropic and chronotropic agent, so it helps with that cardiac output, cardiac index. But then in even higher doses, dopamine targets the alpha 1 receptors. So, therefore, depending on what dosing you're using, it can be high or low. So, dopamine's that awesome wild card. Side effects of dopamine can cause anxiety, nausea, vomiting, diarrhea, almost like any medication that we know, and again, tachyarrhythmias. So what type of shock would you expect to use? This isn't a trick question. That's right, you can use all of the different types of shock for dopamine because it's our wild card. Dobutamine. So dobutamine hits our beta 1 and beta 2 receptors, hence the I love beta. So back over here to our board. Hits our beta 1 and beta 2. So we've got some blue and some orange happening over here. So what is dobutamine going to be used for? Is that going to do anything to our CVP? No. Nothing to the CVP. How about to the cardiac output, cardiac index? Yeah, it is definitely going to do something to our cardiac output, cardiac index. It's going to increase it. How about systemic vascular resistance? Well, it's going to have a mild decrease in systemic vascular resistance. And why is that? Well, going into a little bit further here into our presentation, dobutamine is an inotropic agent, and it's used for arrhythmias as well. Our dosing is 0.5 to 20 mics per kilogram per minute. Again, do that based on your parameters. Side effects can be ventricular ectopies. I mean, we are messing with the pump here, so we have to be careful. It can cause chest pain and palpitations, but it can also cause hypotension. Now, when things get real complicated, so say you have a patient who originally comes in for hypotension and you're giving them something like norepinephrine, which is strong, strong alpha-1, and you're causing that vasoconstriction. You finally got their blood pressure up, but now they're having a decrease in their cardiac index, and you need to start dobutamine. Keep in mind that once you start that dobutamine, because it has a side effect of hypotension, you may be undoing some of the progress that you've made by raising that blood pressure. So you have to use sharp critical thinking skills when you're managing multiple drips and multiple vasopressors. So what type of shock would you use in this medication? Cardiogenic shock. Exactly right. All right. So when we bring it all together here and looking at our board, this is what we find, that we can use all of these different medications for different types, and you can use this as a reference later on. But we are now moving on to our game portion. So in front of you guys, you should see this right here, this little card. You guys are going to divide into groups of 5, and you're going to work on this together. Now over here on the far right side of the far right column over here, it's going to have the problem. So there's multiple different types of problems that you see in ICUs, DKA, GI bleed, whatever you name it. For each problem listed, you are going to indicate the type of shock, so whether it be cardiogenic, obstructive, what have you, what type of shock it is, whether there's an increase and decrease in the CVP, the cardiac index output, the systemic vascular resistance, and the afterload, and then what type of treatment you're going to give for this problem or this patient. So I'll give you guys 10 to 15 minutes, work together, try to figure out what all of these presentations are going to be, and we'll come back. All right, so these are our answers to all of the different issues, the different types of shock. We'll discuss it all together. I'll answer all of your questions. We'll talk about the rationale behind each treatment, and then we'll move on to the next portion of the class, which is simulation. Excuse me. So it is simulation time. So those groups that you just divided out into, you guys are going to be working together as a team. So you are the emergency room nurse coming onto your shift. And just as you walked in, Mr. Smith's rolling in. He's a 75-year-old male complaining of shortness of breath for 3 to 4 days, just general malaise and loss in appetite. So that's all I'm going to tell you for right now. This is going to unfold, but in the simulation, the 5 of you as a team will be expected to gain a medical history, including home medications, perform a nursing assessment, a full nursing assessment, obtain their vitals, and continue to monitor their vitals, because those can change, communicate with providers, and administer medications. So my recommendation would be for the 5 of you to divide and assign different roles. You can have the historian who get the medical history, obtain the different medications that the patient's taking, the assessor, so one of you is going to do a full head-to-toe assessment on Mr. Smith. A third one will be a vitals overseer, because we know in critical care and emergency areas that vitals can change very quickly. A communicator, so somebody is going to be communicating with the providers via SBAR report, and then there's going to be a medicator, so one of you is going to be hanging the drips or the fluids or what have you, and be monitoring those as we go. You all will work together as a team to see the simulation to its completion in order to ensure that Mr. Smith is stabilized and makes it to the intensive care unit. Good luck. All right, so that was awesome, guys. You guys did a great job in your simulation, and watching that unfold and just seeing how Mr. Smith ended up with aspiration pneumonia, and we ended up starting him. He was septic. We got blood cultures. You guys were really sharp in being able to determine that quickly and start fluids, antibiotics, and we ended up starting some norepinephrine and vasopressin on him. How do you guys feel using the norepinephrine and the vasopressin? A little bit better now that you got your hands on it and started using the pumps and everything? That's awesome. Good, good. Well, do you guys have any questions about anything so far that we've covered? Okay. Well, on that note, thank you guys so much. I'm so excited for where God is taking you as a nurse. And if you have any questions, feel free to reach out to me. Here are the references for your reference. Thank you guys so much.